Hello everyone, I am Dr. M. Mallikeshwar Raja, your orthopedic faculty for Medico. I welcome you all for this National Test and Discussion program. Here I would like to highlight a few important things to you before we begin the session. The difference between ordinary and becoming extraordinary is that little extra. I want you guys to focus on three things: perseverance, positive mindset, and quality over quantity. Guys, that little extra which you need to crack the top spot is what we at Medico and regarding orthopedics, I want to give you guys. See, it's not enough just if you read again. The concept of revision plays a major role. And what to revise? Given in this stage, you have access to various materials. In fact, the material volumes have become so much that the students literally these days are feeling confused as to what to read and what to leave, right? So in this session, I have brought upon important set of questions, okay, which will help you revise and recollect all the key facts that are needed to give you guys that extra edge to reach the top level. All right. Remember again, guys, it doesn't matter how much you read. At the end of the day, all that matters is how much you're able to recollect and how much you're able to present on the day of the examinations. So what you revise is very important. With these few words, friendly words, don't take me as in someone like who's gonna advise you all that. I'm not into that. With these friendly few words, let's join hands and revise the important concepts in orthopedics and crack the exams. Like all my sessions, if you had been following me on Medico regularly, I aim to simplify orthopedics in a systematic way because I firmly believe that if you're able to recollect things in a systematic order, it will be easy to remember and reproduce at any point of time rather than learning so much of mnemonics, mugging them up and trying to remember the mnemonics, creating another mnemonic. That's something over the years, after cracking the exam, after finishing my PG, after completing 3 fellowships, what I have learned is this: have a clear concept and go up by it in a systematic way and try to understand what the examiners is expecting of you in the questions, and then we'll be able to crack it easier. All right, guys, with these few words, let's head straight into the session. Okay, so the first topic which we are going to cover is called fracture basics. So without basics we cannot progress further. Okay, let's discuss the first question. So the first question, guys, is which of the following is a pathognomic sign of long bone fracture? When a fracture occurs, just like any other injury happening in the body, all 4 signs of inflammation will be there. Tumor, calor, loss of function, all that will be there. But what is more characteristic? That is important. Okay. Pain on movement definitely is going to be there. Swelling is going to be there. Deformity is going to be there. Abnormal mobility, all of them are going to be there. But the question is a pathognomic sign with which if that one thing is present, you can straight away say that it's a fracture. And for the answer for that is abnormal mobility, right? So let's have a few important one-liners and then get into the concepts, okay? So the most common pathognomic sign of a fracture is abnormal mobility, but the most common symptom is pain. The most common sign is swelling, okay guys? All right. What is a fracture? A fracture is nothing but a break in the continuity of the cortex or the medullary cavity. See, the bone, just like any other tissue, it's like a connective tissue in the body, right? And it has both cortex and the medullary cavity. a fracture means a discontinuity on either of the two. Okay, it represents both. All right. So important classification. Based on this classification, all the basic classification, so many questions comes, and sometimes even though we know the answer, we get confused. Okay, on the day of the exam. Let's get that concepts cleared. All right. So based on the type of trauma which we encounter, how do we classify the fracture as? It could be because of a significant amount of trauma or an insignificant amount of trauma. What we have to understand here is when the bone is subjected to a significant trauma, that is the force enough to break the resistance of the bone, you get all the typical fracture patterns. For example, a transverse fracture, oblique fracture, or a spiral fracture. But if there is an insignificant amount of trauma, yes, the trauma is significant, but how can that cause a fracture? Yes, in certain situations, like if the bone is normal, but you have repeated insignificant trauma, that will lead to stress fracture. All right. If you have a insignificant amount of trauma occurring on an abnormal bone, what are the examples of an abnormal bone? It could be infection, it could be tumor, it could be any metabolic bone diseases. In these conditions, it leads to pathological fracture. But both these things stem from the common testing of an insignificant trauma. All right. So that was classification based on the type of the traumatic force. Now based on the injury pattern which you have when you have a significant trauma, significant force over a normal bone, it's when you will have all this characteristic fracture patterns. Okay. The first most common is a transverse fracture that occurs when there is a tension force. All right. When there is a tension occurring at the site of trauma. All right. If there is a compression force, you will get an oblique fracture. This is an example for an oblique undisplaced fracture. But if along with compression, if you're going to get a shearing force, that usually happens when there's a moment or a heavy object that is moving is forced to stop by another heavy object. There will occur both compression and a shearing force. In that stage, you're going to get a oblique and a displaced fracture. If the force is spiral, okay, if there's going to be a twisting force, for example, in a toddler, when due to abnormal force or like someone is harming the toddler, they tend to twist the bones. Okay, that will lead to a spiral fracture. Okay, in pediatrics, if a child which is yet to walk, if you come across a spiral fracture, all right, on the long bones, it is definitely battered baby syndrome. Okay, keep that in mind for regarding battered baby syndrome. Okay, but at the same time, if the force is significantly heavy and it occurs directly over the bone, all the significant trauma, it will lead to crushing of the bone and crumbling of the bone into multiple pieces, leading to a comminuted type of fracture. Okay, so the common fracture patterns include a transverse fracture, an oblique fracture pattern, a spiral fracture pattern, and a comminuted type of fracture pattern. All right. Now let's solve a few questions before we head into the next topic. All right. Listen carefully, guys. A 25-year-old male is playing football with his friends and lands on an outstretched arm. This landing on an outstretched arm is the most common mechanism for all upper limb fractures. Okay. He is seen in the emergency department and radiographs are obtained. He is taken to the operation theatre for open reduction internal fixation and post-op imaging is given. Which of the following is true in regard to the fixation achieved? All right. Now see the first picture what do you get is fracture radius midshaft. All right. Now in the second picture, we see that it has been fixed with plate and screws. What the question wants is regarding fracture fixation achieved. Let us discuss the options. Relies on enchondral ossification. Fracture site strain is between 2 to 10%. Soft callus is eventually converted to hard callus and occurs via Haversian remodeling. All right. What they want to do, what they want to test in you guys is what are the types of fracture healing, or how does the fracture heal, and how does the surgical intervention affect the fracture healing. All right. Let's discuss about fracture healing and come back and solve this question. All right. Just like any tissue, how the bone can also break, the bone will also heal, either with intervention or without interventions. All right. So, when the types of fracture healing are basically primary healing and secondary healing. See, both of this can be achieved either with intervention or without intervention. That is common. All right. So, let's see what are the characteristic features of primary fracture healing and characteristic feature of secondary fracture. In primary fracture healing, there will be direct bone-to-bone contact. All right. That means there is no gap between the fracture site. By any mechanism, either by POP or by fixing it with plates and screws, you have to bring about direct contact between the fracture site. All right. If you achieve that, usually there will not be any callus formation. There is not going to be any micro movements at the fracture site. Okay. And how do you achieve it? By absolute stability using plates and screws. What happens? Let me explain to you, right? When you bring close contact between the fracture ends and you put a plate and a screw over it, you give a very, very rigid fixation, or in other words, an absolute stability where there is no even a micro movement at the fracture site. All right. That is where the plate and the screws hold both the fragments together. Whereas, if you see the secondary fracture healing, there is micro movements at the fracture site. Don't think micro movements means this much force between the fractures. Okay, it's generally only this much. All right. Because of these micro movements, the callus formation occurs. Okay. But how do you achieve this? By the process of relative stability. And which implant gives relative stability is intramedullary IMIL nail. All right. When you put a rod, all right, when you put a rod into the medullary cavity, usually done for diaphyseal fractures like femur, tibia, diaphyseal fractures for femur and tibia. Suppose this is a fracture site. When the patient starts to mobilize, there is going to be some movement here because you're not rigidly fixing it with a plate and a screw. A nail generally is put in the medullary canal and fixed proximally and distally to prevent the rotational forces, right? So when you do that, there's going to be micro movements, but not very significant movement, just the micro movements. So the fracture is going to heal with an abundant callus formation. All right, callus formation. All right. So coming to this question again, what is this type of fixation? Plates and screws. So what are you going to get? Absolute stability. So absolute stability means what type of healing? Primary healing. If you know that the concept that this is going to achieve primary healing, you very easily can solve the question. I have made it slightly difficult for you because guys, in the training period, if you are exposed to difficult questions on the day of the exam, it's going to be much easier for you guys. All right. So the other name for direct or primary fracture healing is occurs via Haversian remodel. So the answer for this question is occurs via Haversian remodel. All right. Now let us discuss about the stages of fracture healing. Guys, for some reason, the stages of fracture healing and the cells involved in that has been a favorite question for the examiners since my days, guys, and even before that. All right. But recent studies have proved that it is not a 1+1 process that occurs in the body. Rather, it is a combined effect. Okay. And there are so many cells that are involved right from the initial day of the fracture till the fracture gets completely united in a year's time. But for, for the exam's sake, we would still like to classify them so that when questions come from that scenario, you're able to answer them correctly. Okay. How do we easily remember that is, if we take it as initial 2 to 3 days, where any injury, you'll have a swelling and a hematoma. The first cells that are going to happen is the platelets, and the second one are the neutrophils. Okay. The second 2 to 3 weeks is where the inflammation is going to happen, and this stage is going to be neutrophils. So if they ask the first cell that is going to appear at the fracture site, it's always going to be platelets. But after 2 to 3 weeks, in the inflammatory phase, it's going to be neutrophils. In 2 to 3 months, when the inflammation has settled and bone uniting process has started, or a fibrovascular phase, there's going to be more of macrophages. And finally, in 2 to 3 years, when the bone formation is actually taking place, it's going to be T and B lymphocytes are going to be present. All right. After 3 years, still the bone is going to remodel itself. So the entire process of any fracture healing can proceed to something close to more than 3 years. Okay. So with this, if we solve this question, all right, a 45-year-old man presents with a femur fracture following a road traffic accident after 6 weeks of conservative management. What do they say? 6 weeks. So, in what phase of healing is it going to be? All right, we know inflammatory phase is not the answer. We just saw 2 to 3 weeks. Remodeling phase is gradually greater than 2 years. So, the answer for this question is the reparative phase. Right? Another important one-liner to note here is that the first stage of union which we see in the X-ray is the callus formation, which usually starts in the inflammatory phase or at 3 weeks. All right. But don't get confused, guys. Here also you're able to see the callus, but they are giving the weeks duration and asking the stages of healing. If they had mentioned 3 weeks, you should write inflammatory phase. Okay, but here it is not 3 weeks, it is 6 weeks, which means it is in the reparative phase. What is the difference between inflammatory phase and a reparative phase? So that, see, when the bone is left to heal, all right, here they have mentioned clearly it's by POP, all right. First, the fracture tries to fix it with a callus. Callus is like the body's mechanism to stabilize the fracture ends, okay. Guys, I'm sealing this area off because this area needs urgent care, right? So it is like protecting, forming a capsule around the fracture ends, okay. That's what callus does, all right. When that is formed inside, there will be a lot of reparative things happening. For example, when the bone gets injured, all the margin cells can be dead. So those have to be removed. For that, the macrophage, osteoclasts come in, and then the new cells start forming. So that is called as a reparative phase. All right. I hope the answer for that is clear. Now let us look at the next question. Figure A is the radiograph of a 52-year-old male who underwent open reduction internal fixation of a both bone forearm fracture 9 months prior. He complains of persistent pain at the ulnar fracture site. His C-reactive protein and erythrocyte sedimentation rate are within normal limits. What is the most appropriate definitive treatment for the patient? Guys, here what are they asking? They say it is 9 months and pain is there. That means the bone is not united. That's all right. They are giving to you a case of non-union. Okay, they mean to say that the bone is not united. All right. They go on to give additional clues like his C-reactive protein and ESR rate are within normal limits. What are the use of that? To raise if there is any infection seen on it. So there is no infection. What is the most appropriate definitive treatment? All right. Now, before answering the question, let's understand few points about non-union and then come back and solve this question. All right. See guys, since we are all going to take a lot of pride in whatever we know, me being an orthopedic surgeon, whenever I do a surgery, I feel so happy and proud of myself that I have done something good for the patient or I have achieved success. But always remember guys, a doctor can treat, but God will always heal. Even though we feel that we have done the best to our ability to heal the fracture, but God is the one who's going to decide whether the fracture is going to unite or not. But for how long can we wait? Is it like I've done the surgery today, tomorrow everything is fine? No. By definition, they say if there is no callus formation for up to 9 months duration, you have to pull in the diagnosis of non-union. This is very important, guys. How long can you wait for a patient, or how long can you tell a patient that no, we need to do something extra for this bone to unite? So that duration is fixed as 9 months. But do we need to always wait till the point where the problem has occurred already? For example, if it's 9 months, it's already at non-union, and then we'll have to do so much of different procedure. But if we are going to give a little push to the bone much earlier, maybe it can get avoided coming to the stage of non-union, right? So for that, the definition has been amended over the years, and a term has been coined as a delayed union, that is till 6 months. So when the fracture you have treated, even with the best of the technologies, the best of the implants you have done, and even after 6 months you're finding that, okay, there is still no callus or still some pain at the fracture site. Instead of waiting and reaching the stage of non-union, you can do some interventions much earlier. So that is the importance of delayed union. So by definition, non-union means 9 months minimum, delayed union is 6 months. So in the question, it's 8 months, roughly around 9 months. So it is a case of non-union. Right. So the most common bone to undergo non-union is tibia. The most common site being diaphysis. All right. So what are the types of non-union, and why do we need to know is that if we know the type of non-union that has occurred, it will be much easier for us to solve or to treat it. All right. So basically dividing non-unions as hypertrophic non-union, oligotrophic non-union and atrophic non-union. Well, as the name suggests, hypertrophic means there is more than enough callus which is required actually to heal the fracture. More than enough callus. What it signifies, guys? What is I told you? Callus is because of the inflammation, right? The body's own inflammatory mechanism. So if the body's inflammatory mechanism is good, that means the body's biology is good. The body is trying to heal itself, but only because of some problems it is not occurring. So usually to treat a hypertrophic type of non-union, which has good biology, but only the mobilization is inadequate, we will have to do a fresh of the bone ends and fix it with better stability. If you just provide better stability in a case of a hypertrophic non-union, union is going to happen. But rather, if it's an atrophic non-union where there is no callus at all, it states poor biology. That means even though you stabilize it, there is no, the bone is close to dead bone. How is the new bone going to form? In that case, you'll have to give a stimulant for the bone, and that is called as bone grafting. We will have to fix it with better stability as in the case of hypertrophic non-union, but also give bone grafting. What does bone grafting has? It has the cells osteoinductive property, that is, it has the natural bone forming ability, right? So when there is gap at the fracture site, because of bone formation, the new callus can occur. We can improve the biology through that. All right. Let's come back to this question again. Right. So 9 months pain, there is a diagnosis of non-union. So what they're asking is, what is the most definitive treatment for this patient? So if you look at the bone ends, I can clearly say it is a type of atrophic non-union because there is no callus and it is being close to 9 months. All right. In this stage, I told you for atrophic non-union, always and always you should treat it with an osteoinducting property material. That usually is the bone graft. So the answer for this question is revision open reduction internal fixation with iliac crest graft. All right. Let's look at the next question. Which of the following substance is used for bone formation in patients with non-union? I told you, if a non-union is there, you need some substance which can give the bone or bone inductive property. For that, the product of choice is bone morphogenic proteins. They have bone inductive property. The other three that is mentioned here, that is polymethyl methacrylate, PMMA in short, calcium, and all that are osteoconductive. They can be supportive to help in treating non-union, but atrophic non-union which needs the new bone, they are not able to give. For that, we need the bone morphogenic proteins, right? Our next question, very interesting one. See, a 50-year-old male with a history of smoking, okay, 8 months after a fracture. X-ray findings given below. What is the most likely diagnosis? All right. What they say is close to 8 months has occurred. X-rays given below see there's a fracture, but no callus. So that means it is a formation of non-union. All right. I think with the explanation it becomes much easier to solve the questions. Okay. All right. Let's look at the next question. All right. An elderly woman was brought to the OPD after she slipped and fell from the chair. She is a known case of breast cancer with distant metastasis. If the moment this is given, it is a abnormal bone. So, what are all the bone abnormal I have told you? So, it could be either infection, metabolic, or tumor. But here they have said that cause of breast cancer with distant metastasis. So this fracture is more commonly a secondary type of fracture, okay, or a pathological type of fracture, all right. So which of the following statement is false regarding this type of fractures? What they have asked. It occurs in abnormal bones. Yes, definitely. Mirror score is used to assess the risk of fracture. Yes, for in our oncology topic, we'll discuss about the importance of Mirror's grading and Mirror scoring. But here you have to know that for all pathological or tumor related fractures, we always put Mirror score. It will assess or help us reassess the kind of fracture. FET-PT or CT is the gold standard for evaluating bone metastasis. No, MRI is even better. Pain occurs only after the fracture site. This is the point of difference. So pain before fracture. Remember guys, this exam many people can test you on this, that the pain is going to occur before the fracture has occurred. All right. We'll just have a 2 minutes break and come back again. Yeah. Yes. So, regarding these pathological fractures, like we already mentioned, it is due to an insignificant trauma on an abnormal bone, which could be because of tumor, infection, or other metabolic bone diseases. The most common clinical feature is pain before the fracture. Okay, always pain occurs after the fracture, but for a pathological fracture, it is always pain before fractures. Okay. So the investigation, the first line of investigation is an X-ray, followed by, for confirmatory, you would do an MRI. But remember guys, the gold standard, if they ask for any pathological things, always say a biopsy. All right. The gold standard, but confirmatory you can do with an MRI. But if you need to know the exact cause, it's always with a invasive procedure like a biopsy. All right. So the most common location, if you take the cause as the metabolic bone disease like osteoporosis, it's going to be spine more than the hip. Or if it's a case of metastasis or tumor, it's going to be proximal femur first and then followed by spine. All right, remember this, which is the most common cytopathological fracture. If in general they ask, always say spine more than the hip. But if they mention as metastasis particularly, I know they twist it like this, then go for a proximal femur more than the spine. Okay? Yes. Let's look at the next question. A young marathon runner is participating in a marathon competition. After running for about 100 meters, he develops pain at the anteromedial aspect of tibia. All right. So 100 meters he has run and he develops a pain at the anteromedial aspect of tibia. Okay. But increase on further running. The X-ray is normal. What is the likely diagnosis? Guys, it's easy. It's again repeated insignificant trauma on a normal bone. What does this point out to? We all know this. It is a fatigue fracture. Okay. So the answer for this is, which occurs in the tibia. All these are tibia. So it is called as a shin split. It's a type of fatigue fracture or stress fracture. Okay. Look at this question. A 30-year-old marathon runner presents with pain in his shin after increasing his training intensity. Typical history of stress fractures. X-ray is given below. What type of fracture is shown in the image? All right. We all know that, the picture is not quite clear. Rather, the fracture line will be only here, unicortical and not extending bicortical. Remember, usually stress fractures, unicortical. Okay. So the answer for this question is stress fracture, right? Like pathological fracture, stress fracture is also due to insignificant trauma, but it is a repeated insignificant trauma on a normal bone, right? Also known as a fatigue fracture. The most common bone is tibia. The most common bone in the foot where the question comes is second metatarsal over the third metatarsal. So second metatarsal is called as the March fracture, not the third metatarsal, second metatarsal. So investigations is first line is X-ray, then you take an MRI. But in this condition, since there's no pathological involved, you need not wait for a biopsy. So the gold standard also becomes MRI. All right. So the management is usually conservative since it's only unicortical. All right. So it's like repeated loading. On the end, you have a unicortical crack. And since there is no much displacement also, it is better and easier to manage this conservatively. Right. So this is a typical example for a stress fracture or fatigue fracture where you see a unicortical crack and not a bicortical one. Okay. Which of the following bone cells is responsible for secreting the bone matrix? All right. To understand this, let's look at the important bone cells, guys. All right. So, guys, the importance of histology, I cannot further bring it. I mean, the coming exams, they are finding new ways to make it tougher and challenging for you guys. Okay. First, in my days, it should only be the clinical settings. Then they started showing the X-rays, then CTs, then MRIs. Now histology is gone. But I would say this, okay, you want to make it tough for us, but let us take this with a positive attitude that you are giving more clues to us. Right? Imagine in a clinical setting, when you're sitting and seeing patient, if you have X-ray with you, MRI with you, and the histology with you, the diagnosis becomes much easier. Just that we should know how to interpret an X-ray, how to interpret an MRI, or how to find out the pathology or a histological slide. Only for those who don't know that, they may feel, oh God, let's hide this investigation report and let's say some diagnosis. But if we know to interpret that, it becomes much easier and we can give a correct diagnosis at all time. So the famous Hutchinson sayings is, right, the mind doesn't know what the eye doesn't see what the mind doesn't know, right? So it's all about, if you know that, you will definitely pick up that clue. So don't feel, not just in orthopedics, in other things, when they go advanced and they give more things like this, for example, they're given immunoglobulin assay or all that, they're giving us more clues, which will help us crack much better. We can come to a diagnosis much faster. So let's take everything that comes across us with a positive attitude, all right? So I'll explain a few things about the histology so that you're able to pick it up. If you know this, 99% of histology questions, you will ace it, guys. Just look at it. See, usually bone is this pink in color. Cartilage is blue in color. Okay, simple. Now, this is a typical example of a bone lacunae. All right. In the edges, you're going to have some cells. In the middle, you're going to have some bigger cells. And outside, in the extracellular matrix, you're going to have some cells. All right. Very easy. What are the cells we need for bone formation? Is osteoblasts. So osteoblasts are for bone formation, and since they are needed for bone formation, they are usually at the outer or periphery, trying to engage with the new bone or trying to grow the bone and all that. And the osteoclasts, where they are primarily for resorption of the bone, they should be present inside, all right, to eat away the bone. And we know what type of cells can eat away the bones are the macrophages, the giant cells, So which cell can be an osteoclast? If it's a giant cell, all right? So all these huge cells are the giant cells or the osteoclasts. And the cells which are present outside are usually the spent osteoblasts that are present as an osteocyte. So I again repeat, the osteoblasts are for bone formation and they are at the periphery. The osteoclasts for bone resorption and they are at the center. And the spent osteoblasts are the osteocytes. Okay. So bone formation, mainly the markers are increased ALP. So for bone resorption, the increased markers are increased TRAP. Alright, for bone formation, it is ALP, and bone remodeling, it is TRAP. Alright, guys? Now pay attention, close attention to this histology slide. See, what is the difference between an immature bone and a mature bone? See the organization in a mature bone. This pink structure, it's so neat. Correct? So this is an example for a lamellar bone or a mature bone. In an immature bone, see the bone lattices are still framing. Okay, so that's how you differentiate between a woven bone and a mature bone. All right. Now that we have covered the basics of fracture, let's discuss a few points regarding trauma management. Right, they test you guys in this. Right, but trust me, guys, they don't want you to become an orthopedic, they don't want you to give the exam like an orthopedic surgeon where you have to decide about what plate to use, titanium or steel, what nail to use, all that. What they want you is to correctly identify the trauma patient and give the appropriate primary care. Okay, the tertiary care or the final care will be given by the concerned specialist. All right, but they want you to manage it correctly, and that's why the questions, whenever you come across trauma questions, always take it with an open mind. All right, if you see a trauma, orthopedic trauma, I know most of you would like to become or have a dream to become an orthopedic surgeon, right? So we should not approach it as a end point of view, Rather, we should find out what is the first best step we can do. What is the classification of this fracture? What type of fracture is it? How can I stabilize it? That is the first thing that is should be coming to your head. All right. So in trauma, the patient comes in casualty. Whoever comes in casualty, as per the guidelines, it is always ATLS, acute trauma and life support guidelines. What they say is always follow A, B, C, D, and E. So A means you secure the airway. B means breathing. You make sure the patient is breathing. C means circulation. You make sure that the heart is pumping blood to all the vital organs and also to the periphery. And D means disability. E means exposure. Finally comes the disability, guys. So first you'll have to secure the airway, make sure the patient is breathing, make sure the circulation is okay, and then come and look into the deformity or the exposure things. All right. Right. So, in trauma, generally, how do we split it? Either an isolated orthopedic trauma or a polytrauma. With definitions of polytrauma, or I'll come along. So, isolated orthotrauma means you need to ask these three questions. Okay, which bone is affected? What is the deformity, or whether it is associated with avascular necrosis or not? All right, and also assess the neurovascular status. Now, to know this, in a case of trauma, you have made sure that there's an isolated monotrauma. You're going to send for investigations. All right. First itself, the patient is coming to you with a huge trauma, huge femur fracture. You need not order an MRI. So get the investigations first, with which is required to make a basic diagnosis, and then proceed forward. So X-ray you take first, always two views. If it is a joint injury, then you go for a CT, or if it is involving the spine, better to go for an MRI as needed. All right. Okay. We'll just solve this question and go back. Which of the following bone cells is responsible for secreting the bone matrix? We have seen bone formation cells or the osteoblasts. Okay. Now coming to the concept of polytrauma. That is, apart from orthopedics, other departmental injury or other systems are also affected. All right. Say they give a criteria for that. Okay, need not mug up the entire criteria. Just know that if other bones or other organs are also injured, better to handle it with the polytrauma criteria. All right. So what are the criteria which they give is injury severity score of greater than 40, injury severity score of greater than 20. But both these things are slightly difficult to put at the time. If you have a questionnaire, it's much easier. But if you find multiple involvement of systems like respiratory system, abdominal system, take it like an ISS, injury severity score of greater than 40. If one of the systems are not there, for example, if a thoracic injury, everything is extra, then put it as an injury severity score of greater than 20. Okay. Next is head injury associated with GCS less than 8. Hypothermia less than 25 degrees, abdominal or chest trauma, or bilateral femur trauma. Okay. So all these they have considered it as to be the criteria for polytraumas. Okay. In the case of polytrauma, the management protocol which you have to follow is known as damage control orthopedics. That is, you minimize the trauma, what is happening to the patient, give an instability to the fracture site, and then fix the fracture at a later point of time. Why? Because all the fractures cannot be addressed at the same time, because you'll end up causing more bad than good, right? Because of the inflammatory markers, already the patient is in a huge load of inflammatory markers trying to address the other injuries. At that time, if you take the patient up for surgery, again there's going to be another inflammation, another injury, but at that moment the patient can even collapse. All right. So what is the timing to do a polytrauma is 2 to 5 days after the inflammation period has settled. Only life-threatening surgeries has to be addressed first. For example, which are open fractures with or without neurovascular injuries. Okay. So which fracture can be managed what in a case of polytrauma? That repeatedly gets tested for you guys. So fracture dislocation is always important. Unstable spine fracture, you'll have to put a skull fracture. If it's a cauda equina, you'll have to do an immediate surgical decompression. If it's a pelvis fracture, you can put an X-fix and wait for 1. Whereas if it's a cauda equina, yes, you have to do it immediately. Okay. So the definitive treatment can be delayed for up to 7 to 10 days for pelvis and tibia and 3 weeks for femur. Alright. So that point you have it clear. In general, if you are getting an open fracture, the golden rule always says less than 6 hours, but you can take it to 6 to 72 hours. You're going to debride first. Why debridement? Open fractures, the most common complication of open fractures is infection. So a thorough debridement is required. You can put an X-fix to temporarily fix the fracture. Then definitive fixation, when the soft tissue cover or the neurovascular status is healed, you can plan for a definitive fixation. Okay. This is an example for an LRS type of fixate. All right. So what you define by a open fracture is when the fracture is or the bone piece is communicating with the outside environment. Okay. The most common classification used for an open fracture is the Gustlow-Anderson classification. Guys, one thing with me is I don't believe in reading all the classifications and by hearting them, because those days we did not have the advantage of CT or MRI, and patients had to rely on, the doctors had to rely on just X-ray findings to operate on the patient. But at this very age where there's a CT 3D reconstruction, we can get a 3D print model and start doing on that. We need not go for extra retraction because that may cause more harm than good. All right. So whenever the bone is communicating with the skin, it's called as the open fracture. The most common classification for open fracture is Gustlow-Anderson fracture. All right. So how do you classify this Gustlow-Anderson classification is type 1, 2 and 3 are very easily to define is type 1 less than say 1 centimeter, type 2 is 1 to 10 centimeter, type 3 is more than 10 centimeter. Now the confusion occurs when it is more than type 3 as to how to further classify, and why it is required, because if you are putting it as a type 3, you are going to address it immediately. All right. For that, you will have to differentiate it from it is whether type A, B or C. Guys, I'll make it very simple, guys. Okay, let's have it very simple. Wound less than 1 centimeter type 1, 1 to 10 centimeter type 2, more than 10 centimeter type 3. All right. In 3, you need A, B and C. Okay. Or this is emergency. Okay. In C, if there is a neurovascular injury, you put it as C, immediate. The only differentiating thing becomes between A and B. Okay. So easiest way to differentiate between them in the question is look for the word contamination. Okay. Contamination. Gross contamination, you put it as type 3B. Minimal contamination, you put it as type 3A. Very simple. If you look at the book, there will be so many points given in that, but at the day of the exam or at the day of your actual cases, whether you will be able to implement the entire thing is a bit doubtful. All right. So you need a key point with which you can decide. Okay. This is what practically we use. All right. So the most common bone again for open fractures is tibia. The most common complication for an open fracture is always going to be an infection. Right. Now let us solve some interesting questions. Okay. A 35-year-old man is brought to the emergency department following a high-speed motor vehicle accident. All right, you know it is an RTA, right? He is unresponsive and has multiple injuries, meaning polytrauma, including a head laceration, femur fracture, abdominal bruising, everything. BP is on the lower side of 90 to 60. Heart rate is higher. So what is this? Hypovolemic shock. Okay, he's pale and diaphragm. What is the first step in the management? Guys, always the question I told you, they don't want you to be an orthopedician and treat this. They want you to be a good clinician to save the patient, right? So the look at the question is, what is the first step? So immediately when you receive the patient and you see the BP is low by A, B, C, D, E, airway, breathing, circulation, the circulation is affected. Before the disability comes the circulation management. So what is it going to be? You have to restore the circulation. How would you do that? Start intravenous fluid resuscitation. So this is the answer. Don't worry about the fractures or this thing. Always disability comes after A, B and C. Always remember that. That is why I insist on getting your concepts correct and going in a systematic way. If you know A, B, C, D, E, you can very well pick the chance that it is always C coming before D. Alright. Now look at this question. A 40-year-old man is rescued after being trapped under a collapsed building for 8 hours following an earthquake. Okay, massive crush injury. He complains of severe pain in his legs and there is swelling and bruising in both lower limbs. So the entire this thing is crushed. On arrival, his urine is dark and the test shows elevated serum creatinine and potassium. So what is this? Crush syndrome. So when there is so much of crushing, this myoglobin enters kidney and causes acute tubal injury. Alright. So that is why he is having elevated serum creatinine and potassium. Okay. So what is they are asking is what is the most important next step in the management? Like I always say, the first step would be to start IV fluids immediately. Okay. Always remember, you have to stabilize the patient. Since the kidney is flushed with myoglobin, you need to flush them out with fluids. Right. The next question. A 28-year-old motorcyclist presents to the emergency department after a road traffic accident. Okay. His tibia is visibly fractured, the bone is protruding to the skin with significant bleeding. His neurovascular status is intact. What is the appropriate immediate management? Okay. They say it is fractured tibia, open, and no neurovascular injury. Okay, what is the immediate priority? Immediate priority, remember, in a case of open fracture, it's not surgical fixation, it is always going to be fluids or antibiotics. They know you will be forced to answer immediate surgical fixation, but always remember the first line would be fluids or antibiotics. Yes. Let's come back after a few minutes, guys.